Welcome back to Women Making Moves, where we celebrate the moves that women are making. My name is Amy Pons, founder of Unlock the Magic Coaching and Healing. I'm joined today again with Nurse Betsy Elizabeth Kelly, and this is the second time only out of about 200 episodes that we've had a repeat guest. So that's exciting. And we're going to try not to edit this, so we'll see how it goes. Elizabeth Kelly, NP, graduated from Illinois State University in 2004 with a Bachelor's of Science in Nursing. As a registered nurse, worked in the medical intensive care unit and emergency department at Northwestern Memorial in Chicago for 10 years. A passion for caring for vulnerable populations led her to move abroad to work with the international aid organization, Doctors Without Borders, where she lived and worked in Ethiopia and Malawi. Elizabeth obtained a Master's of Science in Nursing from the University of Illinois Chicago in 2012 and is a board-certified adult geriatric primary care nurse practitioner. For the past 13 years, Elizabeth has been a nurse practitioner at Sinai Chicago, seeing patients in surrounding nursing homes, managing patients with a broad and complex need of subacute rehabilitation, primary care, psychiatric and substance use disorders care. This is a pivotal time for women's health in the United States. We're seeing drastic improvements in education and access to menopausal hormone treatment, while at the same time watching a maternal health crisis continue to unfold, particularly in states with intent to criminalize both women and healthcare providers for reproductive health care. On April 30th, 2026, the Department of Education issued its final rule on the updated definition of what is a professional student. Despite strong objectives communicated by the general public, the American Academy of Nurse Practitioners, the American Nurses Association, hospital systems, and nurses themselves, nurses were deemed not a professional degree. The implications of this ruling is federal loan limits restricting access to graduate nursing programs and exacerbating an already severe shortage of nurses, nurse educators, and primary care nurse practitioners. Now, more than any time within the last 50 years, have the stakes been so high, requiring all people who still believe in the American dream to continue to speak up, speak out, and advocate for access to healthcare, education, and domestic safety. Be welcome.
Hi, I
Oh
wish it was
gosh.
under different circumstances, but it is not.
Oh gosh. Okay, so yeah, this is the second time we've ever had someone back, so I'm excited to chat more with you. When you reached out to me, you're like, "Hey, can we have a part two? What's up? Why do you want to have this?"
Well, when there has been a lot of change, our initial conversation was about hormone replacement therapy and the removal of the black box warning. And in the last 6 months, myself and many other providers are trying to catch up and learn and absorb as much information as we can, because we were not taught about midlife women's health. And so we are all catching up, we are all learning, and it is a great time for women entering perimenopause and menopause, because they're going to have access to treatment that for the last 20 years women have been deprived of.
As we explore more, and like when we talk about maternal health crisis, we talk about our own mothers that are post-menopausal, but also never got the treatment that they needed. My mom is mentally unwell from a various amount of factors, and they just started talking to her about HRTs, like her testosterone levels are alarmingly low, and that's starting to be looked at, and everyone's just so shocked. And I'm like, well, right, this is just stuff we didn't know before. And I don't know if it's like, I don't know if it's Gen X that's going to have the first big wave of these powerhouse women that are getting on the meds in time. I don't know. And like millennials are going to be the next one. I don't know. What is it?
And actually, what's even more devastating than that is it is exactly just like for elder millennial, like it is that generation who went through perimenopause and menopause between 2002 and now. Because in the 1980s, 1990s, hormones were prescribed. It wasn't until the WHI came out with this study in 2002, and the study was not bad. And this is something that I have just been consuming, all of this data and this information and the updated the updated studies. The WHI was not a bad study. It was, unfortunately, the way that it was communicated in the media was inaccurate at best and misinformative at worst.
So wait, which generation got the HRTs before this? Like, so how old are
Well,
they now?
yeah, so in the 1980s and 90s, so like our moms had
Oh, so
access.
grandmas.
Yeah,
Grandmas
grandmas
had HRTs. Okay.
grandmas had access in the 80s and 90s, there was all this data coming out about, okay, like reduced risk of fractures, prolonged life, reduced risk of cognitive decline, of cardiovascular disease. And then all of those positives, which are still there, and now we are now seeing in these follow-up studies, was all negated by this exaggerated percentage of, this very extreme and unnecessary fear mongering of breast cancer.
Okay, so grandmas had it, then our moms would have been skipped. X might be benefiting it from it right now if they're open to it. And then obviously we as elder millennials, we're like on the cusp of peri, so maybe not quite yet, but it might be soon. So really it's the boomers that miss. That sucks. Oh my gosh, boomers.
Yeah.
Oh, boomers.
Yeah, and I see it. I see it because with the newer studies that have come out with the KEEPS trial and the ELITE trial, it is very clear that when you start menopausal hormone treatment, that's another thing. They're trying to move away from HRT because HRT is the treatment of hormone replacement in early menopause, whereas perimenopause and menopause is menopausal hormone treatment. So they're trying to move kind of shift the language for it to be, more accurate to what it is. That's that.
So what have you learned since last time? Since the
So
black box was removed?
yeah, so when women are prescribed hormones, menopausal hormone treatment within 10 years of their last period, it is only not harmful. It is not only not harmful to give, it is important that you give it because estrogen is cardioprotective. You see all of these improvements in reduction of fractures, femur fractures, hip fractures. And the difference between some of these newer studies and the WHI was the WHI was just oral. It was just oral estrogen and this certain form of progesterone. And now we know that almost all of those risks in terms of blood clots and the risk of breast cancer, where it's estrogen receptor based cancer, a lot of that, almost all of it can be minimized by using transdermal patches. So there is very few clinical reasons to not give at least transdermal estrogen and progesterone if a woman has a uterus to women within 10 years of their last period. Believe it, Heather Hirsch, she is a very, very well-known, she's out on social media. She's trying to get the word out. She established the menopausal clinic at the Brigham Young Women's Hospital in Boston. And she stated, we're doing harm in the name of do no harm. That is one of her kind of consistent mottos, and it's true. So if we're not sure about something, we do nothing, but in doing nothing, we are harming women. And it's unfortunate.
And I see it as like, especially if we're talking about boomer women that missed this or the let's just say boomer gen. The boomers that missed out on this, I'll speak from personal experience with my boomer parents. They're extremely stubborn and they dig their heels in the sand on what they knew or what they learned. And so at this point, even though the whatever treatment it is that's coming back around or that was never necessarily unsafe for all, etc. Even though it's coming back around, I don't even know who would be able to convince them.
Right.
I mean, because like I can't even get them to take a vitamin. So,
Yeah.
like, I mean, it just, I don't know. It's like, and
Right.
that's the thing too, like even mainstream physicians, there's still a lot that are not supportive. So then, well, okay. I don't know. I don't know what it's gonna take.
Absolutely. And that's another reason, that's another thing in the last 6 months or so, I have tried to increase my presence on social media. I didn't have an Instagram account up until like last June. Because scientists and medical professionals, not always the best communicators, right? And if you leave a void, especially in social media or in the media in general, then that void, that vacuum is going to be filled with misinformation and with people who are either misinforming because they are misinformed or misinforming because they are opportunistic. So it's important for people of medical background and of good intent to get the word out about what their options are, so women are not led to get certain compounded things that are not regulated or that are not necessarily the right dosing. So it's important that people of science step in and provide women information. Otherwise, it's going to be misinformation.
And would you say that Generation X is open to this, or like are they following suit with boomers, or are they more like us, where it's like, give me the stuff?
I think Generation X, because here's the thing, like these women women are smart. Like we sense it. Like we already know,
Yeah.
like the brain fog is there. The night sweats, the like wanting to like rip your husband's head off because he's chewing too loud. Like we feel it. And so I think Gen X is going to be open-minded to it because they are feeling these symptoms and they're going to be like, "Oh, I can finally have relief." And so as long as there is not this continued fear-mongering about breast cancer, then I have hope that women are going to start seeking treatment and get the help for the symptom management that they need.
And is it that I guess something that I was surprised about was that my mom is so postmenopausal. I was surprised that she would still need some sort of support or treatment.
Mhm.
Is it going to be the rest of our lives?
So here's the thing. So hormone, this is sort of kind of how the breakdown there's different menopausal types, right? So you have the premenopause, and you have women who are now menopause by definition being 12 months without a period, and then the postmenopause, right? So that period after you've no longer had a period for 12 months. And menopausal hormone treatment comes in all different, it is so individualized for every woman. And it just depends on whatever the woman's symptoms are. So there are four FDA-approved reasons for menopausal hormone treatment. It's the vasomotor symptoms, like the hot flashes, night sweats, genital urinary symptoms of menopause, and what's what's the last one? Oh, osteopenia. See, I'm like, perimenopause moment and osteopenia. So those are the four FDA approved reasons to provide menopausal hormone treatment. However, we know as clinicians and as women that estrogen is not just a sex hormone. It is involved in our mood, our muscular skeletal systems, our hair, our skin, our libido. It's involved in all of these areas. And, when taken early, the cardio protection and the bone protection. So it depends on the woman. So, and the risk factors. So it very much depends. So for some women, they may, especially if they went through surgical menopause early, they may need to continue on in order to have symptom management for their whole lives. Maybe early on, you could take oral medication, and as you age, like the women in the WHI study, they were on average 63 years old, your risk factors change. And so you might need to go from an oral estradiol to a patch in order to minimize some of those other risks. So it depends on every single woman. And that's why it's so important for clinicians to be educated about having menopause on their differential diagnosis, because in the last 6 months that menopause, perimenopause, and menopause have been on my differential diagnosis list, I have prescribed hormones instead of other medications and have had good results. So even if you're having a symptom and you're not sure if this is perimenopause or menopause, you can even just do a trial of hormones and see if it helps. And if it didn't, and you're still feeling depressed or you're still feeling this irritability, then maybe you do need to, do other medications for your mental health. There's very few reasons to not offer hormone treatment to women.
And I want to revisit something you said. What are we talking about right now? It's not just HRT. How do you position them?
Right. So HRT, and this is something that really has been shifting, even like it used to kind of just be this whole umbrella of HRT, like this hormone replacement therapy. However, the hormone replacement therapy is different because typically the doses of hormones are higher. And usually it is for more severe symptoms like of surgical menopause. Women who have gone through a total hysterectomy at an early age. And so you have to give a higher dose in order to manage those symptoms. And in menopausal hormone treatment, you are able to use different forms of estrogen, primarily estradiol, and in smaller doses. And that in itself is helpful because, again, the WHI study was oral medications, and it increased risk of blood clots and other and the breast cancer, but it was oral medications. We've moved so far in the last 20 years that the risks are not the same. The side effects are not the same. And it affects everything in medicine, almost every specialty.
And what will we see between grandmas? Well, actually, let me ask you that. Even though grandmas could get it, I don't know. I know my grandmas. I'm not sure they would have even gone down this road. So do we know that they even did it?
Like the 80s and we don't I
Yeah.
don't
Like,
know.
did they?
Yeah, there's different. So I would say I would have to look to see what the specific numbers are, but I mean, menopausal hormone treatment was not, I mean, it's women's health, right? So it was never great. But
I feel like my one grandma would be like, that's what was she called? Like snake oil or something
yeah,
that
yeah,
she would
yeah.
have been like, meh.
Yeah, or like this is natural. It was also there was some shame put to it, like right, like this is just a natural part of aging, and so like why are you going to try to, mess with this? This is natural. This is nature. I'm not gonna do anything that is not part of what's like the natural system. But we know that, I mean, that's part of what we learn in science the more that we learn, we can optimize these things because women weren't always living to be 80, 90 years old. So we're living now almost a third of our lives in this postmenopausal period. And our health, how healthy we are going to be in that last third of our life for women between the ages like around 45 to 55, 40 to 60, that sets up what our health is going to be like in those last 3 decades of life. So it's really, really an important time because the gains that you get from menopausal hormone treatment are you see the gains when it is started earlier.
And then so I guess I'm trying to kind of deduce what we would see holistically out in the collective if there were this gap between grandmas and Gen X.
Mhm.
Are
I
are
can say I can say this, right? So whenever you do a study and you would expect so estrogen and progesterone. So, and just to clarify, so menopausal hormone treatment can be a variety of different things. So like estrogen can be given to a woman, just estrogen alone can be given to a woman who doesn't have a uterus. If a woman has an intact uterus, then you have to add progesterone in order to protect the lining of the uterus. And then the vaginal estrogen can be used, it's more localized. And so even if women have high risk of DVT or clots, pulmonary embolisms, you can still use local vaginal estrogen. And testosterone, you're going to be really excited about this one. So, because the primary indication for testosterone, and we talked about this the first time I was on, you asked if insurance was going to cover testosterone. And I said, hopefully it should. That was optimistic.
I thought so.
Because the primary indication for testosterone is for reduced libido. And because we live in the patriarchy, there's no reason for a postmenopausal woman or perimenopausal woman to have improvement in libido because they're not making babies. So why does it matter if they want to have sex or if they want to have orgasm?
Okay. All right. All right. So let's just stop having sex. All right.
Yes. So that is the pushback that we are getting on testosterone because you can also you don't there's risk to oral testosterone, which is why you don't give it orally in terms of like your liver and your lipid panel. Um, but there's testosterone gels now, and so you can use very small amounts, and they have not done any really significant studies on if it helps with women's muscular skeletal, which would be really helpful to know. But of course, there's been like no recent studies to see if there's any correlation or causation with testosterone and improved muscle mass, because we know that's a huge problem for women postmenopausal is a decline in their muscle mass. And so that's just one example of something that would be really helpful to have as a clinician, but because women's health is not prioritized, we don't have that information.
I
And
mean,
if women want to take testosterone because they want to have a healthy sex life and and be connected with their partners, insurance very likely will deny testosterone because there is no FDA indication for women because reduced libido is not considered an FDA a necessary reason to give to women.
let's see how, like everything, there has to be a large scale male impact for something to shift. So if you know, all hetero partners, like the women of hetero partners just stopped wanting to have sex, then there will, that's just silly.
And you're right though that this is where I had mentioned like this is a time where we need to advocate and we need to be out there. That includes healthy males, right? Men who are in healthy relationships and families and who they don't have, there's a lot more men out there like that, than it's not all men just wanting to, just be able to continue to have sex with, young women. There's a lot of healthy men and we need them to speak up more too, because they are a voice of reason. They are the example of what masculinity is. Men who want their wives to be healthy and happy and sexual beings. And we need, just like we need people of science to kind of push back on misinformation, we need healthy males, healthy men with grounded confidence and men who have healthy masculinity to push back on this toxic masculinity, this sense of, women should be submissive, this whole kind of movement backwards, like the Heritage Foundation type of movement backwards of what
It,
traditional
it's
gender roles, right?
it's yeah, traditional gender roles, and let me go into energy for a minute because that's my thing. So energetically, and we're talking about like soul energy. There is no gender, and I call it kind of the new human energy or the new or balanced energy where a human can feel into both beautifully their masculine and feminine. And what's interesting is, yeah, um, toxic feminine is like the submissive of being less than. A healthy, balanced feminine is when any human can feel into their softness and feel safe and secure and strong. That is a healthy feminine. Can you imagine? And oh, by the way, as a person who identifies as a woman, I have been in my masculine energy most of my life because that is what has been mandated from me to survive out in the workplace, out in the world. And when I'm able to actually feel into my feminine and feel soft and feel safe without being harmed, I just got full body chills. That is like my ideal state. And I dig being in my masculine too, but like there are very few opportunities that I can feel safely soft.
I not only 100% agree, but I can also personally relate to that as a woman who I am educated. I am able to, when I was going through an unhealthy marriage, I had to constantly be in my masculine.
I remember.
And,
Yeah.
and right. So it was this sense of I have to take care of everything. Like it's this sense of this hyper sense of need for control because you don't trust anybody else to
Mm.
take care of things for you or to be there for you physically, mentally, emotionally. So you have to do it for yourself. It's that
Yeah,
it's
and it's not even something that like we're making up, like they're not. Like
no,
we have to, because otherwise everything will fall through the cracks. It's not just this tier. It wasn't like a false sense of control. It was like, no, shit will fall through the cracks if I don't do this. And it's like not being able to feel like you have a moment to be vulnerable or let your hair down or just like, and oh, by the way, everyone deserves this, not just women. Like we all deserve a moment to feel soft and feel like we can just take a moment for ourselves, but that's just not the vibe that we've had for the last 100 years or longer.
no,
Um,
absolutely. And to touch back on that, in terms of I was in that place at one point and I was in that masculine energy for so long and it wasn't a healthy place for me.
mm,
It's that sense of that hyper independence as a trauma response.
mm,
And it took me many, many years and a very understanding, healthy man to be able to soften that.
Mhm.
And my example that I gave to my daughter the other day, because my daughter's going to be in high schools now, so she's, kind of navigating all of this, right, with relationships and like, and I told her, I said, the most masculine thing that John, my husband, has ever done is he went to an accountant with me and helped set up my business. And then we went out to dinner, and he didn't realize that it was like a gay bar, like with excellent tacos and drag queens, and he had the best time ever. Because it was delicious and like it was fun, and we were doing like drag bingo, and he like so he spent the entire evening supporting his wife in her business, and then going out and not caring that, like, okay, I'm a cis male.
Assist.
I'm a cis male, but I can go out to a drag bar and have some tacos and play some bingo. I'm like, that is the most masculine thing I have ever seen. Like he just, because he doesn't care. It's like
Yeah,
that. I'm like,
it doesn't matter.
that is big D energy.
Yeah, it is. Right. Something I'll share about my husband every time we go out to eat, every single time, they bring us the opposite drink because he always gets a margarita. I always get a beer. And so when they came back to the table, they always give me the margarita. He was like, nope, that's mine. It's like, yes,
Yeah.
okay. To be held by, oh my gosh. And we've all been, and not just my husband, I've been around males that can hold strong women, and holy hell, is it amazing. Like, because suddenly the world shifts, it changes. I don't have to be on guard. I don't have to have my walls up. I don't have to have I used to like my energetic field. When I'm having to be in my masculine, like hardcore masculine, I I almost feel like at the end of my energy bubble, it's like what's that barbed wire. That's what I feel like is at the end of my energy bubble. That's what I'm leading with. And you know me, like we both know each other. There are people in my current life that only see the barbed wire because of what they present to me.
Yeah.
And
Yeah.
and like so it's probably such a wild notion that I could be anything other than that. And that's the beautiful multifaceted, but like again, that's not mine, the way that they treat me. That's their own of I mean, maybe I'm a catalyst and we're all catalysts for each other. And oh, by the way, none of us are separate. Anyway, that's another whole nother soul-licious conversation.
Oh,
Um
I mean, and that even the soullicious. I believe that like all of these things are interconnected. I have a great example of this. Um, my mother-in-law was having really severe vertigo and headaches, and she stopped taking some of her medicine, and she was doing some other kind of grounding techniques. And my husband was like kind of poo-pooing the grounding
oh
technique,
no.
right? And it was like involved with like a copper, kind of like a copper thing, and but it was her and I went and I took her blood pressure, and her blood pressure was like 190 over 110. Okay. And I'm like, okay, Tina, you need to take your blood pressure medication. Okay, so like I'm gonna get you all set up, and let's get these refilled, and let's make sure that your blood pressure is within a normal range. And then I pushed back a little bit on John because he was like, it's placebo effect. I said, no. I said, because if she was feeling a calming sense, what do you think that did to her blood pressure? That would have dropped her blood pressure. So that mental effect had a physiological effect. And
Of course
so,
it
right?
does.
So like keep the copper grounding. And then also if your blood pressure is still too high, then we know that you still need to take your blood pressure medicine. But you can't skip out on both, like you may
Mm-mm.
need both, right? But
Listen, if I'm outside talking to a tree, leave me be. I'm not hurting anybody. Like
yes,
if I'm outside wearing a tinfoil hat, unless it's like lightning, I mean that okay, sure, maybe bring me inside. But like who are we hurting? Let us be. Okay?
Yes, and that's why, and that's another thing that's really important for people, people who are trained in Western medicine, is there's a reason why people are kind of pushing back on Western medicine, because it has become like very corporate and very like push meds, and or like, I'm going to do this procedure because this is what I'm going to get reimbursed on. I can see why people are going, and seeking care elsewhere. And that's why it's so important to make sure that people who are trained in Western medicine are open-minded to everything, because just because it's not what you understand or it's not what you believe to be true doesn't mean that it doesn't have an effect on this person. And so we, as Western trained medicine, we need to be more open-minded to the holistic picture, because it's not nothing. I guarantee that her techniques she was lowering her stress levels, she was meditating, her stress levels were coming down, and her blood pressure dropped. Not enough to where it was safe. Like, she still needed to take her lisinopril, but it helped. And so let's do both.
Yeah.
Let's do both.
Let's do both. It gets to be both. So let's beautifully talk about, for the last few minutes, some of the things we both love, which are supplements or
Oh,
vitamins to help assist with. And now, again, with vitamins and supplements, like, it's ideal that we get things from diet, yes. And that's harder with the types of food we have and things like that, etc.
yes.
Diet and exercise, yep, 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 yep. And some of the things that I've been really jazzed about lately as it relates to being on the cusp of peri is magnesium threonate, creatine for brain fog, focus, clarity, cognitive health. Collagen. And there's this great collagen creatine combo that I take, and I really dig it. So what are some of your faves that we can kind of do as well?
Yes, absolutely. So I did kind of we did this together. We did kind of discussing like on primary care, like what should be most important, and we discussed this, just as among friends. And magnesium, love it for sleep, love it for relaxation. There's different types of magnesium. Some of them can cause some side effects, but like desirable side effects, like magnesium citrate can give you diarrhea. But if you're constipated, like, hey. And then magnesium for sleep, because it's a smooth muscle relaxant, so it can just kind of quiet your body. Vitamin D deficiency is a thing for anybody living in a cold weather state. You have to take vitamin D. I did a vitamin D level on one of my patients the other day, and he struggles with depression. He's actually doing TMS right now. He is a 30-year-old, very fair-skinned Caucasian male, and he had a vitamin D level of 12. And the minimum, you should be between 30 and 100. And I told him, I'm like, that is the lowest vitamin D level I've ever seen in a white guy. Like, what are you like? What, like, you need to get sun, and you need to take vitamin D, and you need to take 5,000 units daily until it's up to at least 30. So vitamin D, magnesium, omega-3. It does not have to be omega 369. It can be just omega-3. That is the one that is the most important to supplement, because 6 and 9 either come from our own bodies or it comes from our diet. And yeah, there's L-methylfolate, because we know that a lot of people have this MTHFR variant, where that's where they lack an enzyme to break down folic acid into folate. I'm doing tempest testing on a lot of my patients, and it provides the breakdown of if you have that variant, and I'm seeing a lot of MTHFR variant.
So my mom has that. Does that mean I have it?
Very likely, yes. So
Oh,
because
wow.
there's a genetic predisposition to it. So I wouldn't say for positive, because there's traits, but I am seeing it. Probably, so I probably since January have had 40 people. It's a solid 75% of people that have some form of the variant. So it's some are it's on different grades. Like, some people are like, they can't process folic acid at all. Some are 70%, some are 30%, some are it's no problem. So it's to different varying degrees, but for about 75% have at least some variant to the MTHFR. And so those people, it is very important that you supplement with L-methylfolate, 15 milligrams daily, because the folic acid that is in your multivitamin, your body cannot use. And there's more data coming up, because that is something, especially for pregnant women, to think about, because we know that, folic acid, folate is very important for neural tube defects in early pregnancy. So that's a really important, all of these things coming up about supplements and non-medications. These are just as important sometimes as a medication you would get from a pharmacy. So, an example of the collagen, the one thing that I would say with that is that is an example of where somebody is taking advantage of somebody, because you hear a lot about like collagen face creams, and collagen is too large of a protein, of a molecule, in order to be absorbed transdermally. So the collagen skin products, I wouldn't recommend. It's going to be very moisturizing, but you don't get the effects. You have to take it orally in an
Oh yeah,
oral.
that's not what I don't do topical. Mine
No, I
goes,
know. I know you, and you do.
I know.
I know you do oral. So, but yeah, so it's something that, add it to a smoothie, but don't pay extra. Don't pay extra for like collagen in skin products.
Mm-mm. And there's like I was reading more about it too. There's like it's not just one, there's like one types 1, 2, 3, 4, and 5 collagen too as well, anyway. Yeah, do your research, understand beyond the wrinkles what collagen can do overall. Anyway, because it has a lot of great benefits, but yeah, not just a topical, not just skin, not just like what it looks like.
Now is a time that it's really important that you have a doctor, nurse practitioner, PA, somebody that you trust, that is going to give you honest, evidence-based feedback, because some things are really helpful, some things are snake oil.
Mm.
And there are a lot of people right now out there selling snake oil, and it's for profit. And it is in the name of, there's a reason why it's $1 billion industry, like the wellness industry, right? So it's important that you have somebody that you trust, somebody that is prioritizing your well-being in every way. So whether it be through medicine, whether it be through therapy, whether it be through coaching, whether it be through meditation, all of that is important. And it's important to be with somebody who is doing it for you and not because of financial gain.
Yeah, agree. Uh, Thank you for the second hour. Where can we find you? How can we support your work?
Yes, so I am a licensed nurse practitioner in the state of Illinois. So I can see patients, anybody living in the state of Illinois. I'm actually applying for my full practice authority this year. And yeah, so my office is in Oak Brook, and that's where the transcranial magnetic stimulation machine is, for treatment-resistant depression. We are also starting up Spravato treatment in the next 6 months, also for treatment-resistant depression. I'm at Stay in Your Cortex on Instagram and Facebook. So even if you live outside of the state of Illinois and you are just looking for information and kind of, evidence-based clinical stuff that you trust, I am trying to post more and share and tag trusted healthcare providers, coaches, therapists who care about your well-being.
Closing remarks this time as we wrap up.
Yes, closing remarks. Unfortunately, I spent time in Washington, D.C., advocating for the federal student loan program for nurses to be considered professionals. And unfortunately, on April 30th, that became a final ruling. And so not just for nurses, but also for physical therapists, for speech pathology, there's education. There is a long list of female-driven professions that are now going to have reduced access to federal student loans for graduate programs. So now more than ever is an important time to save money, to know what you want to do, and have the agency to do what your dream is, even though there's a lot of energy pushing back at you.
Thank you, B.
Thanks, Aim.